Good morning. So my lecture again is on guidelines for pain evaluation, risk assessment, especially for opioid abuse assessment, and documentation. I have no financial relationships to disclose. Oops. All right, so an overview of guidelines. Dr. Sandbar kind of alluded to this earlier. There are a lot of guidelines, hundreds, ranging from very intricate international guidelines to more specific medical society guidelines. And most of them state that we have two really main duties. And one is to ensure that controlled substances are available for legitimate medical purposes. And number two, to protect our populations against abuse and dependence. I don't think we have much problem in the United States with number one. This is a World Health Organization graph that shows, I don't know if I don't think the laser pointer is working, but it shows that the United States has 5.5% of the world's population and consumes 55.9% of the world's medical morphine. So our main duty is to protect our populations against abuse and misuse. So for this lecture, I used two main guidelines to put this lecture together. The first is a joint venture between the American Pain Society and the American Academy of Pain Medicine. I like this guideline. It's a little longer than most. It's more detailed. It has a lot of really good information. And in the appendix, it has a lot of real practical tools for physicians to use. It has a template for an informed consent, a template for an opioid management plan. We used to call them contracts. Even in 2009, they were called agreements. And from what I hear, we're not supposed to call them agreements anymore. They're now management plans. These were published in 2009. And the other guideline I'll use today is a model policy that was adopted by the Federation of State Medical Boards in 2004. Our state medical board has also adopted this model policy, so this is very applicable to everyone in the audience. This I like almost for the opposite reason that I like the other one. It's very short, very concise, easily read in one sitting, just a few minutes. The preamble is actually longer than the guidelines, so very easy to follow. So first, looking at taking a pain history, this isn't so different than taking any other type of medical history. Gosh, I'm sorry, you want to pay, all right, you want to look at the development and timing of the problem. So an acute pain problem, you might gear your treatment more towards trying to treat the underlying cause of the pain, whereas a chronic pain problem, you want to put together a chronic pain management plan. You want to look at the intensity of pain. This is something we can track through time and see if any of our interventions are actually helping. You want to look at the character, evolution, associated symptoms, all these things that can give you clues as to what's actually going on and help you treat the underlying cause. The last bullet point there on previous treatments, I used that before I even knew it was part of the guidelines. I think it's very practical. These pain patients a lot of times have gone a lot of places, tried a lot of things. I keep what I call a failures list, and sometimes it gets to be 20, 30, 40 different failures long. So if I'm thinking, you know, what happened when we tried gabapentin? I can look back on my failures list, oh yeah, it caused some dysphoria or dizziness or whatever. Also, in practical terms, these days with insurance companies denying just about anything we want to do, it's kind of nice to have the failures list so it makes those appeal letters a little easier to write. Also, looking at the guidelines, again, like any other medical history, you want to get a past medical history. You want to pay particular attention to psychiatric history in these pain patients. This will play a role later when you're assessing possible opioid abuse risk. Same goes for social history. You want to look at support systems. I am continually amazed. You know, I try to schedule someone for an injection and they need a ride to and from their injection therapy. And they can't find a ride. They don't have a family member. They don't have a friend that can take 2 hours out of the day to bring them to and from an injection. You want to look at their home life. their work life, their job satisfaction. That plays a key role with workman's comp cases and whether they might be filing for disability. Do they smoke? You want to look at a personal and family history of drug and alcohol abuse. A personal history of drug and alcohol abuse is the most strongly predictive factor for future aberrant drug-related behavior. So this is going to play a key role in risk assessment. You want to know if they smoke. Does their family have a history of drug or alcohol abuse? Any current history of prescription drug misuse? Are they exercising? Are they sleeping? Is their pain interfering with their sleep? Is their sleep affecting their pain? And are they involved in litigation? And last part of the history guidelines, you want to do a complete medical records review, obviously looking at diagnostic tests, anything that might help you actually figure out what's going on and be able to treat the underlying cause. Physical exam guidelines. The guidelines are pretty vague on this. Most of them just say do a physical exam. Some of them will say do a more detailed neurologic and musculoskeletal exam. But none of them are any more specific than that. I wanted to take a minute while we're on physical exams to talk about Waddell signs. These are often part of a pain management physical exam. These signs were put together by a physician named Waddell in the 1970s, and he felt that these pointed more towards non-organic origin of pain. And for those of you in the audience that don't know what these are, there's 5 different signs, and they're things like the superficial sensitivity. So, you know, when we do an exam, we're palpating the patient and trying to figure out where the maximum point of tenderness is. And with these Waddell signs, you know, there are some patients that hurt everywhere you touch them. They moan and groan and jump and cry, and you just can't figure out anything. They tend to overreact. A lot of times they have this give-way weakness that's not a typical motor deficit weakness. And so over the years, these signs started to be used as an indicator of malingering or secondary gain. In 1998, Waddell came out and said he didn't think that was appropriate, that even though it might be an indicator of non-organic pain, he really didn't think it was a sign of malingering. And they've done a lot of studies since then that have confirmed that there really isn't an association between high Waddell signs and malingering. So those probably shouldn't be used for that purpose anymore. One of the more recent studies I thought was really interesting. This study took patients and put them into 2 groups. Several groups, but they put two through an MRI scanner. One group scored very high on Waddell signs. So they had 4 or 5 positive signs out of 5 possible. The other group had low scores, either 0 to 1 out of 5 possible Waddell signs. Then they subjected them to this intense tactile stimulation, which was basically like an MRI-compatible TENS unit. And they cranked that TENS unit up just shy of pain. So it was intense, but the patients didn't say it was actually painful. They put them through the functional MRI, and the normal patients, the ones that scored low on the Waddell signs, they had more activation of the normal parts of their brain that are involved in sensory processing than the Waddell signs high. So these Waddell signs high scorers probably just aren't processing the sensory input. They may actually be feeling more pain. It might be, you know, some psychological overlay. It might still be kind of non-organic origin, but probably not the malingering. And last point on evaluation of pain, obviously, if appropriate diagnostic tests haven't already been ordered, go ahead and order them. Those might be imaging studies. They might be diagnostic blocks. Then moving on to assessment, looking at risks and benefits of opioid therapy. With any medication we prescribe, we always have to weigh benefits versus risks. With opioids, we kind of have a 3rd tier to worry about, and that 3rd tier is the risk of substance abuse, misuse, addiction, and diversion. So first, looking at assessment of benefit, one of the questions we need to ask is, could this pain condition be more effectively treated with a non-opioid? So if someone shows up to your office with trigeminal neuralgia and they haven't been tried on any medications yet, you probably wouldn't grab an opioid first, maybe an anti-seizure medication. When I was in training, I was taught that neuropathic pain did not respond to narcotics. I thought it was kind of interesting the APS guidelines state that they think neuropathic and nociceptive pain respond equally well to narcotics. I think the truth is probably somewhere in between. Neuropathic pain, I think, does respond to narcotics, maybe not quite as well as nociceptive pain. So what type of patient benefits most from opioid therapy? Usually they have moderate to severe pain and they failed other non-opioid therapies. Who benefits least? These are typically patients that have poorly defined pain conditions, have unresolved compensation or legal issues, and I would add also typically have psychological overlay. And these are the patients really that respond poorly to almost anything we do, whether it's medication management or injections or surgery. So we need to look now at risks of opioids, and again, typically we look at side effects, adverse effects. This first slide shows some of the more common, well-known side effects of opioids, things like respiratory depression, sedation, and cognitive impairment. A lot of these things after an adjustment period, the patient will typically kind of get over. And even the cognitive impairment, there are a lot of studies that suggest that after an adjustment period, chronic opioid therapy, or COT, may in fact improve cognitive functioning, which I think just goes to show that pain can really interfere with concentration and the thought process even more than opioids. Driving is kind of in the same category. Your driving doesn't improve on opioid therapy, but after an adjustment period, typically the driving reflexes that are slowed at the beginning are no longer slowed. And so generally people think that it is safe to drive on chronic opioid therapy as long as the patient does not feel sedated. GI effects, the nausea and vomiting, usually will resolve after an adjustment period. Unfortunately, the constipation does not. And so the patients need to be told that they need to start a good bowel regimen right from the beginning. Urinary retention and pruritus are also pretty common side effects. Kind of some less well-known side effects, this xerostomia, dry mouth. I have had several patients come to me and tell me their dentist told them that their cavities are all because they're on narcotic therapy. There might be some truth to that with the dry mouth, and now with all these new mouthwashes out there for dry mouth, it might be something that the patient should be warned about, and they can talk to their dentist about maybe getting on some of those mouthwashes. Opioid hyperalgesia is kind of a hot topic. And so the patient should be counseled that narcotics do have the potential to actually worsen their pain over time. Myoclonus is usually seen just with high-dose opioid therapy. Sleep disordered breathing can be a problem, especially for patients with pre-existing pulmonary conditions. And so maybe ordering a sleep study as part of the initial assessment before starting a patient on opioids wouldn't be a bad idea. As far as endocrine effects, opioids have been shown to reduce testosterone, but I will say that pain has also been shown to reduce testosterone levels. And then menstrual irregularities can be associated with opioid therapy. So the last tier in assessing potential abuse or a potential risk for opioid therapy is looking at potential abuse. So as I said earlier, a personal history of alcohol or drug abuse is the most strongly predictive factor for aberrant drug-related behaviors. In one study, when opioids were prescribed for patients with no history of abuse or addiction, the rate of abuse and addiction was only 0.2%, and that's compared to 5% in patients that were not pre-screened. Other factors to look at, a family history of alcohol or drug abuse, that's probably the second most predictive factor. A younger age, male gender, psychiatric comorbidities, history of sexual abuse during childhood, all raise risk. conviction for driving under the influence, history of lost or stolen prescriptions, and using supplemental sources to obtain opioids. I think all those kind of go back towards just the history of personal abuse. So there are some screening tools that we can use to help assess a patient's risk for opioid abuse. And as I said, a lot of these are available in those APS guidelines. Unfortunately, none of these screening tools are lie detectors. Most of the screening tools, it's kind of obvious what the right answer is and what the wrong answer is. And so if you have somebody in the office that's trying to game the system, they can pretty much answer these screeners, I think, and get a good score. And so if you have your doubts, that might be a time when you want to send those patients to a psychologist who might have some better tools available. This is one tool that I really like, partly because it's simple. It's pretty easy to administer during a busy clinic. It has only 5 questions with some subcategories. And this one, the other reason I kind of like it is it's not necessarily one that the patient has to answer. You can pull most of this information from their social history or from outside medical records. So it might be a little less easy for the patient to just go down the list and answer the appropriate questions. If you do want to give them the questionnaire, it looks just like this without the little grading score out to the side. But the questions on here are things like family history of substance abuse, personal history of substance abuse, and then the subcategories are which kind of substance, alcohol, illegal drugs, that type of thing. Then their age, history of pre-adolescent sexual abuse, and psychological disease. Another of the screening tools, this one might be a little more well-known, is SOAP, the Screener and Opioid Assessment for Patients with Pain. This is 24 questions, so it's a little more detailed. Only 14 of them are scored. And these questions are things like, how often do you feel that your pain is out of control? How often do you have mood swings? And this last one that I've included isn't so much a screening tool, it's one of the few tools available that you can use while the patient's on opioid therapy, which is kind of nice. It has 17 questions, and all of them start with, in the past 30 days. So in the past 30 days, how often have you visited the ER? In the past 30 days, how often have you used your prescriptions in a manner that was not directed by your physician? Things like that. And so last slide goes over the documentation guidelines. This is pulled directly out of that Federation of State Medical Board policy that's also our state medical board policy. So you should do pretty much everything I've kind of gone over this morning. Document medical history and physical exam, diagnostic, therapeutic, and laboratory results, any evaluations and consultations, treatment objectives, that you have discussed risks and benefits with the patient and you need to get an informed consent for opioid therapy. What treatments have they tried? What medications are you prescribing? And especially with controlled substances, you need to document the date, type, dosage, and quantity prescribed, instructions and agreements, and periodic reviews. And my very last slide, I'll just plug the most recent issue of our State Medical Board's newsletter. They had a very nice article in there about prescription drug abuse. Thank you.